really have to push hard in order for the microphone to go on. Well, good morning, everybody. It's 10 o'clock. Welcome, everyone, to the Health and Hospital Committee meeting. Going to call that to order. I am Supervisor Otterly, Chair of this committee, along with Vice Chair, Supervisor Margaret Abekoga. With both supervisors present, we have a quorum. All right. And then going to next is item number 2 is a public comment for members to the public to talk about items that's not on the agenda today. So, hi, Peggy. How many folks do we have who would like to speak in public comments today?
Good morning. We have no speakers in chambers. We do have one hand in the Zoom room.
Okay, let's do 3 minutes.
Apologies, 3 minutes?
Yes.
Or 2. Our first speaker is Michael Rogers. Please accept the unmute to begin speaking. You will have 3 minutes.
Hi, can you hear me?
We can.
Okay, great, thanks. This is Mike Rogers. I'm chair of the Health Advisory Commission. I posted an input in writing to this meeting, giving a legislative update on things that the commission is involved with, primarily integrating functional medicine, but also toxins. News this morning, actually, breaking news, is the Nobel Prize for Medicine was given out for work on unraveling the immune system. And one of the 3 winners is a primary functional medicine researcher. So it's a great item for the emerging part.
We have a hard time understanding him. Yeah. Yeah, hold on for a second.
Mr. Rogers, your connection is not great. Not sure if you can get closer to your mic or move locations.
Can you hang on 1 second?
Yes.
Hold on 1 second. Let me switch audio. Can you hear me now?
Much
that's
better.
better.
Oh, yes.
Okay, so news today was the Nobel Prize was given out to a functional medicine researcher for unraveling the immune system with 2 people for stuff that's been working on this for 20 years. In terms of legislative updates, a key one was AB 1975 was vetoed, which would have made permanent the CMS 115 waiver for Medicaid food as medicine, which, for example, the Recipes for Health program in Alameda County uses very heavily. We're not quite using it extensively in our county yet, but it's a key pillar of integrative health and addressing the root cause of chronic disease. Governor Newsom said, please bring it back for next year's budget. We're working with local legislators to see that they can do that. They're hesitant given it was vetoed, but we're going to push on that. SB 682 was vetoed, which would have banned the PFAS forever chemicals over concerns about the cost to consumers, in spite of the fact that non-PFAS alternatives are already widely available in the market at competitive costs. And then a big one that was a positive was AB 1264 was signed into law, which will ban ultra-processed foods in California schools, co-sponsored by the 401c3 East Bay eatreal.org, who actually partners with a school in our county, Morgan Hill High School, to transform food delivery programs for students. The challenge to this is the big agriculture and food corporations are circling as to define what ultra-processed foods will mean when this actually gets defined in regulations in the next couple of years. But it's a big improvement. More food is delivered to kids via schools than all of the fast food restaurants and chains in total. Right. And then the last one, there's a key issue that's happened because of the impasse in Congress on extending funding for the federal government. There had been a lot of telehealth temporary measures that have been passed since COVID that enable telehealth and reimbursements. And they're basically suspended on October 1st because it's not as important as trying to get the funding for the whole federal government. There was a great center, the Center for Connected Health Policy in Sacramento has provided a lot of advisement. They track policies and regulations. They've put a nice summary together table of what CMS has already issued on this on October 1st, but they also have a FAQ.
That concludes our speakers.
Okay, thank you. Just want to tell the speaker, if anything else you want to talk about that has not been covered, you can send a copy of this to our clerk, and we'll add it to the record as well. All right, seeing that, let's move on to the next item, which is approval of the consent calendar. On this one, I would like to also add item number 6 and number 9 onto consent. 6 is the monthly report of the Office of Veteran Services relating to staff's Sergeant Parker Gordon Fox Suicide Prevention Grant Program. Item 9 is the report from the Santa Clara Valley Healthcare relating to acquisition and integration of RMC. Just want to check to see if there's any other changes from my vice chair.
No changes, and happy to make the motion.
All right, great. We have a motion, and I will, of course, second that.
And a quick vote?
Yes, let's see if there's anybody in the public like to speak on this.
We have no speakers this morning.
Okay, no speaker on item number 3 in consent. Let's go take the vote.
Vice Chairperson Abe
Aye.
Chairperson Lee?
Aye as well.
Motion carries.
Good. Moving on to number 4, which is the recommendation relating to medical staffing at our Valley Medical Center, O'Connor, St. Louis, and Regional Medical Center. And let's see.
Thank you, Chair Lee. I believe we have Dr. Patty Salmon, the president of the medical staff, online.
She is online with control of her mic. There she is.
Good morning. Good morning, Supervisor Lee, Supervisor Abe Koga. This is Patricia Salmon. I'm the enterprise president of the medical staff. I believe you have our recommendations before you, and I'm here to answer any questions you may have. Otherwise, kindly seeking your approval.
Very good. Thank you, Dr. Salmon. And any public would like to speak on this item?
We have no speakers.
Okay, let me go get a motion.
A motion to approve?
I'll go ahead and second it. Let's go take a vote.
Vice Chairperson Abe Koga?
Aye.
Chairperson Lee?
Aye as well.
Motion carries.
Thank you, Dr. Salmon.
Thank you so much.
Item number 5 is recommendations relating to federal and state health policy and budget landscape. And to present today, we, of course, have also Bert Margolin of the Margolin Group, I believe, yes.
Yes,
He
sorry.
is.
Good morning, Mr. Margolin.
Good morning. How are you? So, the federal budget landscape continues to be exceedingly bleak with current government shutdown showing very few signs of moving towards any kind of agreement. As we all know, healthcare and the impact of H.R. 1 has been at the center of the shutdown fight. There have been 2 key Democratic asks relating to healthcare. The first has been a repeal of the $1 trillion Medicaid cut, which will produce as many as 50 million people losing their health coverage. And the second ask extends the Affordable Care Act enhanced premium tax credits that are set to expire at the end of the year, extends their life. Democrats on the Medicaid cut reversal don't expect to prevail on this item in the current budget negotiation, but they do view this effort as the first step in what will be a long and difficult struggle to mitigate the impact of H.R. 1. They're using the budget impasse to shine a bright light on how irresponsible these cuts are and how outrageous it is that 50 million people will lose their health coverage and hospitals will close unless these cuts are rolled back. It's all part of building the case. That's item number 1. As far as item number 2 is concerned, the enhanced premium tax credits, that's a different matter entirely. There is a chance of actually resolving this issue through the budget fight, and that's why in many respects this is item number 1, ask number 1 for the Democrats. The major reason is that the facts involving this tax credit expiring are clear and alarming. If these tax credits expire at the end of December, 24 million Americans who are on the exchange system, and in California we call this covered California, will see on average a 100% increase in their premiums during the renewal period, which we're about to begin. That's a shocking number. It means thousands and thousands of dollars of new premium costs. It means people will, in many cases, drop coverage. And if their medical history and family conditions require them to keep their coverage, it will mean tremendous financial stress for, again, a large population of Americans. We see Republican arguments against this extension. A main Republican argument has been that this enhanced tax credit was passed during COVID. It was an emergency, it shouldn't be allowed to be extended. But in fact, while it was passed during COVID as part of the American Rescue Plan, everyone knew from the moment the Affordable Care Act was passed in 2010, everyone knew that the credits were probably going to be inadequate over time. And in fact, they proved to be inadequate. They weren't generous enough. And there were efforts over many years before COVID to fix this system, including in California, a law signed by Governor Newsom that did a California version of this fix long before the American Rescue Plan was passed. So this is an ongoing structural problem with the ACA. It's now been largely fixed. Thanks to this fix, the population of people covered by the ACA exchanges went from 12 million in 2021 to 24 million today, a massive increase. So Democrats and others don't want to see this reversed, don't want to see this go away. The success of this program alone is not the reason for some optimism, because there are many other programs within H.R. 1 that are very successful, and Republicans have wanted to dismantle them nevertheless. The premium tax credit is different because it has a disproportionate impact on red states. Red states expanded coverage far faster than any other states did during this last 4-year period. In large part, that's because many of these states are states that did not expand their Medicaid program, had a larger uninsured population that qualified for the tax credits, and when they became available in this more generous form, they rapidly secured them. So in Texas, for instance, the exchange population has increased by 255%. And in Florida, during these last 4 years, 5 years, the number of people on their exchange increased by 147%. And also, the typical exchange enrollee is a small business person and their employees. It's a key constituency for Republicans. So now, Congresswoman Marjorie Taylor Greene is demanding a credit extension, and many of the Republicans are with her, just not quite so loudly. It will still be a challenge to get this done, even though we have some bipartisan support for it, because a majority of House Republicans are dead set against doing anything to help the Affordable Care Act. Speaker Mike Johnson recently called these tax credits a boondoggle and made the plainly incorrect argument that subsidies always increase prices. And because this is a subsidy, it therefore is increasing prices, when in fact all evidence is that it's doing the exact opposite of that. But there is this ideological resistance to the Affordable Care Act, and it hasn't gone away. The fight is demonstrating, with Marjorie Taylor Greene and some others defecting, that members are oftentimes reluctant to take benefits away from their constituents when they've already been received, and when taking them away will produce the incredible anger that this doubling of premiums will clearly create if it were allowed to go forward. So what's the current state of play? The current state of play is the Republicans continue to say, let's talk about the credits, but only after Democrats vote to reopen the government. Democrats fiercely reject the notion of a delayed negotiation because they have been asking for this discussion, this negotiation, for many months. It's not a new issue. It's not a surprise issue. And Republicans have ignored them. They have no confidence, if they vote to reopen the government, that at some future date, Republicans will engage in a negotiation that was always available to them and could have been done months ago. Both sides are very dug in. Republicans think, this is their logic, that Democrats will fold if there's enough pressure on them. Beyond the normal pressure from unpaid federal employees, President Trump has tried to ratchet it up by canceling $28 billion in blue state infrastructure projects. He's initiated another round of mass firings through a reduction in force. Senator Thune, the Senate Republican leader, has begun to force votes on military pay, even though the president has worked out a way to pay the military without the need for a vote. The Senate Republicans are trying to embarrass Democrats by forcing them to vote against military pay, and I put that in quotation marks because they're actually not doing that, but that's the exercise that's being engaged in. And then the last reason why Republicans are dug in is they think Democrats will be blamed for the shutdown because the party that starts the shutdown, which has historically been the Republican Party in past shutdowns, has always been blamed. This, of course, ignores the fact that in this current shutdown, all the public polling already is showing that Republicans are being blamed more than Democrats. And this is there are many differences, but another key difference is prior to the shutdown, the president's DOGE effort was dismantling and disrupting government. It makes it much harder for the Trump administration to come across as the defender of an open and stable federal government. So those are Republican factors. Democrats are dug in because they've reached their limit in watching President Trump ignore Congress's constitutional role in making spending decisions. They are outraged that for the first time in the modern history of the Congress, the party in power is refusing to have any type of discussion about a continuing resolution with the minority party. No precedent. This has never happened before. And they've reached their limit. They're just not going to tolerate it anymore. And Democrats are dug in also because they believe that fighting to stop health insurance premiums from doubling for 24 million Americans is a fight worth having and a goal worth going all out for. So they're both dug in. There are daily press conferences on both sides blaming the other. There is one small piece of progress that I should probably note, in that a group of bipartisan senators have started floating. They're talking to each other. They're on the floor. They've floated the idea as of yesterday, bringing up two bills on the same day, one to reopen the government and the other to extend the Affordable Care Act tax credits for only 1 year. And there's some Democratic senators interested in that, but the Democratic leadership has rejected this idea because a 1-year extension is viewed as very inadequate. It will still trigger premium price increases, not as large as letting the tax credit expire, but a 1-year extension creates uncertainty in the insurance market. There'll still be large increases, and the stability only lasts for a few months, because within a few months, people will begin to anticipate those credits expiring again. And at a minimum, Democrats want a multiple year extension. But it is the beginning of a negotiation of sorts. However, that's on the Senate side. The House remains a major obstacle. I mentioned Senator Johnson's view of the credits as a boondoggle. He's gone beyond that, of course, in that he's kept the House in recess for weeks now. And he's done that because he wants to avoid what's been happening on the Senate side, because when you're in session, members talk to each other. And on the Senate side, some ideas are being batted around. On the House side, by keeping members gone with no floor session, there's no informal back and forth going on, no discussions going on. The leadership has maximum control. They don't want bipartisan brainstorming, and it's just not happening. So we're in a very dark place right now. This is the longest shutdown in history, ended in 2019 at 34 days. This shutdown has the potential to break that record. That completes my report. Happy to respond to your questions or comments.
Thank you, Ms. McGorlin. Let me see, any public who would like to speak on this item?
We have no speakers in chambers and no speakers in the Zoom room.
Okay, thank you. Vice Chair?
Oh, thank you, Chair, and thank you, Mr. Margolin, for the report. Not great news, but what's new these days, huh? My concern, you mentioned that there's a likelihood of this shutdown breaking the record, the last record of 34 days. My concern is how will the prolonged government shutdown impact our county services? So it might be for staff to answer that question. But.
So we do have some impacts already, in the sense that we can't submit on certain grant portals or receive certain approvals, et cetera. But the next major impact that we would anticipate seeing is to the CalFresh program if the shutdown continues past November 1st, where the state will then not have the funding for the next set of payments. And we would see impacts to beneficiaries as a result of that. So that's probably the next big area. If it continues for a significantly extended period of time, we could see impacts to healthcare-related funding, but those funds are paid on a more periodic basis, and so it would have to be a very prolonged shutdown to see those disruptions. But the social services funding would be impacted starting in November.
Are we notifying our recipients of this possibility so that they have some, some advance notice to?
Yeah, go ahead, Greta.
Yeah, I was just going to chime in on that question to say that our social services agency is just starting to get some direct communication from the state about their analysis relative to what opportunities they see for the state to very temporarily backfill, if any, some of these opportunities. I did see a communication shared with me just yesterday by our social services agency director saying that the statewide association of county welfare directors was anticipating that the state itself would be sending out some notices to beneficiaries. And so we're happy to make sure that the board is apprised of what the state determines is the most appropriate mechanism for notification. But it does sound like, given this is a statewide issue of concern, that they may choose to do the beneficiary notifications themselves to make sure it's uniform across counties.
Okay, great. Thank you. Will we know what the state is able or will be able to do prior to November 1st? Or
We would certainly hope so. I mean, it is a statewide issue, and these are statewide benefit systems that counties administer, but the state, they're uniform across California. So, so we would expect the state to take the lead in communication and, probably is trying to scramble to figure out contingency funding sources to try to avoid disruption to the extent possible.
Thank you. My other question might be back to Mr. Margolin is Proposition 50 is on our California ballot. Should this pass, what do you think that will do for other states, particularly red states who might try to continue to tip the scales, per se, to keep control of Congress for the Republicans?
Right, well, the red states are already pursuing that strategy independent of what California does. And my understanding of the issue is this is all a response to Texas, which started the process. Other red states are doing their own work to change the lines, and Governor Newsom and the legislature decided that there needed to be a California response, and that in order to have a more equal playing field in this very unusual election map dynamic, Prop 50 needed to be on the ballot and put before voters. So I think the actions in other states are going to go on whether Prop 50 is there, not there, passes or fails, and that Governor Newsom is trying with Prop 50 to create some equality with California being a factor in the ultimate outcome.
Thank you.
I just want to add one more thing on the redistricting front nationally that's very concerning. The U.S. Supreme Court heard a case this week regarding the Voting Rights Act. And this case is likely to lead to the evisceration of Section 2 of the Voting Rights Act, which in turn, projections show might allow as much as significant redistricting in certain parts of the country that might result in a swing of as much as 19 House seats. So this is on top of what we're seeing right now with the gerrymandering in red states across the country. And it's possible that a decision in that case could be issued early enough. And in fact, the Supreme Court's been asked to issue a decision early enough to allow for that to affect even 2026. So that's on top of what we're seeing already.
All right, on that happy note, thank you, Chair.
Gee whiz. So thank you so much, Ms. McGowan, for the very comprehensive and sad news that we are getting. And thank you, County Executive, for bringing up the issue regarding the risk of what might happen to all the work that's been done through the civil rights movement in the 60s that's resulting in the passing of the Voter Rights Act. And one thing I listened yesterday to one of the podcasts is to truly understand what the Voting Rights Act and civil rights movement was about is really the final act that makes the results of the Civil War, when all those amendments, those 12, 13, 14 that was passed, that really didn't happen, right, because the number of people voting was still so low that the Voting Rights Act and these civil rights movements is where it changed the number of voting for certain African-American groups in some southern states from like 7% to 60%. And so it really enables folks to really, truly able to understand the importance of voting and able to get to the polls. And so that's why these laws are absolutely crucial, and how we are moving backwards is certainly something that's alarming, to say the least. So I just want to say thank you for bringing that up, number one. Second is the issue of the impact we talked about. Many of our residents in our county, about 60,000, are veterans. And the VA, Veterans Administration, is just one organization where we are also seeing the impact. So I don't expect an answer right now, James, but if you could give us an off agenda later on, how the VA is affected such that our veterans potentially is affected in our county. I think I would like to know more moving forward.
Sure, we can look to provide some of that information, and and obviously there's a whole array of services that are shut down right now, including our ability to interact with federal staff, which we do on a daily basis across numerous programs because they're furloughed, and those impacts compound as each day passes. It's not linear, right? As each day passes, the impacts of delays pile up, and it impacts all services that we work with that require federal approvals and other things like that too. So there's a lot of ramifications. We also know that it affects the state's work, because there's a lot of programs where we're not the direct entity interfacing with the federal government, but the state is, and the state then cannot unlock certain things or provide certain guidance or direction absent what they need from the federal government, and so that has a trickle-down impact on us too.
Exactly.
So, but it will provide some specific information on VA.
Please. Yeah, exactly. Thank you very much. And how these are really impacting people's life day to day. And we are day 17 of this shutdown, right, since October 1st. The record, Ms. Margolin says 34. So at the very least, we're already halfway there, assuming this one will be only 34 days, which at this point doesn't look like there's an end in sight, unfortunately.
Yeah, I don't think there's a real serious effort, candidly, to move forward, especially on the House side.
Right. It's like playing chicken and nobody's moving at this point, right? All right. Ms. Margolin, the other question I have is regarding the most recent special election in Arizona. There was a special election to replace the former Congress member Grijalva, and his daughter actually got elected in that special election. I believe the election took place about a month ago now, but she has still not been able to be sworn in to Congress, with the speaker citing that the shutdown's the reason, which I don't believe at all that's at all the law or the state of things, other than the fact that he doesn't want to get her sworn in because she's a member of the Democratic Party, the other side. I just wanted to get your thoughts on that one.
Well, there is no legitimate reason for not swearing her in. Members have been sworn in similar circumstances in the past, and the speaker's reasoning has changed almost from day to day. At one point, he said that he wanted her to be sworn in with all the pomp and circumstance that you get when the full House is in session, which is just a cosmetic factor, and one that she's rejected. She wants to be sworn in immediately. Mm-hmm. The Arizona Attorney General is preparing a lawsuit on behalf of her constituents, because there's 700,000 Arizonians who do not have representation in Congress. Every day this swearing in is delayed, and there seems to be no legal or reasonable explanation for this beyond a desire to keep the Democratic numbers down for as long as possible.
I did hear that she did get the keys to her office in Congress, except there's no phones, no email, and no services. So that really says a lot of what's going on in the United States Congress, number one. Second is there's also a talk about how she was supposed to be another signer of some type of a bill that would then release the Epstein files. Right. So I wonder if that has anything to do with that. But in any case, that might be just more talk, but just to share with everybody how dysfunctional our Congress is currently, and it's certainly very much self-inflicted, which is very, very sad. All right, on that happy note, Ms. Margolin, thank you very much for that, and I will go ahead and we have a motion to receive the report.
Motion to receive the report.
And I'll go and second that.
We have no speakers. Vice Chairperson Abe-Koga?
Aye.
Chairperson Lee?
Aye as well.
Motion carries.
Thank you very much.
Thank you.
All right, moving on to item number, I believe it's 7, which is a report from the custody health relating to the withdrawal care. And I believe we have Dr. Luna and your team here. Good morning.
Good morning, Vice Chair Lee and, Chair Lee and Vice Chair Abe-Koga. Rocio Luna, Director of Custody Health Services. With me is an expert panel that is here to answer any questions you might have. We don't have a formal PowerPoint or presentation for you, but the expert panel that I've assembled here can speak to the various processes of withdrawal care. I'm just going to have them actually introduce themselves. And
Great,
I'll start with my
please.
right.
Hi there, I'm Tiffany Tahata. I'm one of the physicians with Custody Health, and I'm an addiction specialist.
Good morning. Dr. Jennifer Cole, Nursing Executive.
Good morning. Yichao Wang, Medical Executive.
Michelle Delacay, I oversee CalAIM.
Okay. Great, thank you very much. Let me see, since there's no report, I want to see if there's anybody in the public like to speak on this item regarding custody health.
We have no speakers in chambers and no hands in the Zoom.
Okay, all right, I'm asking the vice chair, you have any questions on this one? Sure. Yes, absolutely, yeah, we have been dealing with these issues quite a bit, and so I do have a few questions below and see if we could work on. So jumping right into the questioning, Dr. Luna and your team, one was, what type of percentage of individuals, for those who has begun the medical assisted treatment in custody, has successfully continued the treatment after the release, and if that number is being tracked?
Thank you for the question. I'm going to ask our team to support us here. As you know, the follow-through when folks leave our services, very challenging to actually follow up. So there was a study in 2024 done by our pharmacy team to see, who continued their medication treatment after they left custody. And in that study, there were 91 individuals that were tracked. Many of those were lost to services, and so we reviewed a set of 61 folks whose records we could access, and of those 60 or so, only 7 continued their treatment afterward. So, it's very challenging to track. It's not something we're well set up to do once folks leave us, but those records that we do access, we're able to review, and unfortunately, it's pretty low. It's not low just here, it's actually a national trend, and Dr. Tahata could probably add a little more if she'd like.
Just echoing that it is a little bit difficult to track, that we'd love to track the follow-up rates of treatment, in part because of lack of access to data and data sharing, especially for those patients who transfer to other facilities. Many times that data is not available to us.
Dr. Hara, thank you. So you point out something that I was not aware of at all, which is the not able to share the data. The reason these are not shareable is because of different privacy laws and whatnot for different jurisdictions or different medical care facilities. Am I correct? So I see the light of Greta, yours was on. Go ahead.
Yeah, I was just wondering for context if it might be helpful to just talk about where for these patients you're seeing them go, because I'm making an assumption here, but I assume, for example, CDCR may be a destination for many of these patients, and I'm not sure how much the state provides information to us or access to an ability to understand when someone leaves our custody and goes to state prison, for example, what continued treatment they may be receiving in that system.
Yes, in part it is due to exactly what you mentioned with CDCR, as well as other county jails.
Okay, so the issue is not so much they're being released. We're talking about folks who actually get transferred to other prisons, like the state prisons or other jails, but they do not track or they do not provide or share those information with us, period, because of privacy issues or they just don't because they don't want to?
I'd assume it's a combination. I'm just given many experiences with trying to share data with other county systems, with the state, that the kind of logistical complexity of it. So it's not as much a legal prohibition in that under HIPAA, if we are doing care coordination, for example, with that entity, there's an ability to share our health records, certainly to them when they're taking over responsibility for care for the patient, and some limited ability for us to request information on whether patients continued to receive care. But I think in many instances, the logistical infrastructure to share information back and forth is a significant barrier, particularly where you're talking about various different health systems which use various different electronic medical records. Lots of counties utilize contracted service providers to deliver the custody health function. So you wouldn't even be seeking that information from the county government itself, but rather from the entity that they contract with to provide care. So having tried to facilitate in my past roles in the county, lots of data sharing between governmental and non-governmental entities, including in the healthcare delivery context, it's often quite complex, and especially when you're dealing with so many different destination points for different patients, that makes it even harder.
This sounds like it's a Sacramento legislative fix if we really want to get into it. At this point, given the current system, there's really no way to break these silos, right?
I would say it's perhaps also just sort of a funding and infrastructure challenge, less a legal challenge. So systems have the ability to share that, but may not have the interoperability and the data sharing agreements in place to do so. Although, of course, from a pure continuity of care standpoint, I don't know if you want to speak a little bit to what information, for example, CDCR is able to access in terms of when we are transferring a patient into state custody, how they're accounting for understanding what medical needs, including in the substance use treatment area, that patient may have.
That's a question either, I think, Dr. Wang, who actually came to us from the CDCR, or Michelle, who oversees our discharge planning support.
So I'd like to echo what Greta said. In terms of the difficulty in sharing information, CDCR uses a different electronic health records, and CDCR does have a very robust substance use disorder treatment program, and we can actually look into this further and find out more information for you if you want.
Yeah, I think it would be helpful, especially with your prior experience at CDCR. I think it would be great that we could use that knowledge and try to see what we could do to figure out, because the numbers we're looking right now is very low, but part of it is not necessarily due to the fact that they are not being treated. It's just that we don't have the information, right? So I think it would be important for us, because at the end of the day, the continuum of care is exactly what we're looking at. We've done our part,
Yes.
but when somebody's transferred, we certainly want to make sure that it doesn't fall into the hole or gap, let's say. And if they really are no longer getting the services needed, of course, then they fall back to addiction, then basically feel like everything we've done is all for naught. And that's what we don't want to waste resources that way either, right?
I'm happy to look into it.
Yeah, please, if you can just get back to us on this, I really appreciate it. Go ahead. You have a question?
Just to follow up on that, I guess I'm trying to understand then it sounds like the tracking afterwards is difficult. So how do we track those who are continuing care, or if I'm assuming we help with the transferring over, but how do we work to ensure that they're going to be able to, or they're continuing their treatment so that they actually recover? It seems like if the data is not there, how are we able to figure that out?
Yeah, I'm looking to Michelle, but I'm hoping maybe she can kind of distinguish between two things. One being there's the opportunity and need we have to make sure folks have access to care when they leave custody. And then there's the challenge, even where they have access, of actually, will they show up given the voluntary nature of continued substance use treatment? And also perhaps Dr. Trow may want to weigh in as well on the outpatient substance use treatment services that folks have access to and through what mechanisms, particularly as they leave custody. But maybe Michelle can kick us off.
Sure. So when somebody leaves the carceral setting into community, there's a number of different ways that that might happen, known or unknown, programmed release. There's so many different areas. Even if they leave and enter our system of care, which is likely where we had some information about that, our VHHP program at the Reentry Center sees a lot of people on a walk-in basis. We've just received additional information about the Compass Clinic and where they can walk in and receive services there. So there's opportunity for them to do that. And there's a voluntary notion that Greta mentioned about whether or not they will choose to do that. When they leave unanticipated, and they may or may not have an ability for us to reach out to them to help support them when we have an unplanned release, that's something that we're looking at on trying to help streamline that process and ensure that they have the information that they need. I know that the teams that work in the custody health setting tell them about that every time that they see them in the custody health setting. So they're set up for success. And we were talking just the other day about ensuring that we also include the Compass Clinic for those that may not feel comfortable or safe going to the reentry center. So we're giving a lot of opportunity for that. Knowing that it happens, or benchmarking it to what the community standard is for continuation of services is going to be important, but also helping us see when they're in our community. We live in the Bay Area, and so there's a lot of cross coverage in other counties, and so a lot of people will go to San Mateo, or they may fall out of service of care. So all of those things kind of intermix and intermingle. If they're getting a dual diagnosis or a programmed release where they're getting services for mental health and substance use, that falls into potentially substance use treatment, which then adds an additional barrier to understanding and data sharing. So they may get services in substance use treatment, and that is not able to be seen under HIPAA. It falls under 42 CFR Part 2, which is a higher standard of care, and we can't share information. So it gets very complicated. We send the information to the receiving entity, and we give the patient the information that they would need to be successful in that. But we do have challenges in just knowing if that was followed through. So.
I just wanted to add one bit of context that's been a topic of a lot of discussion at Public Safety and Justice Committee, but of course not as much here, which is the complexity for our care teams and the reality of who they're seeing in custody. So there is a huge, overwhelming majority of our custody population touching down briefly in custody, and then, as Michelle mentioned, leaving at times that are unknown. They, as soon as the court orders someone released, we have to release them, and there's often not any time for our teams to help plan for a smooth transition out of custody, and we cannot hold them longer in order to do that planning. So often there really are very significant barriers to what would otherwise be this sort of transition to an out of custody setting that you might see if someone were being released from the hospital, for example. Just not the same kind of factual reality on the ground where we have, and then as been mentioned, a lot of the folks who are in our custody longer are transitioning actually to CDCR, some out into the community, and wherever there is knowledge that someone's going to be with us for a while and then transition out into the community, that's where the care planning and transition planning is really happening. But that's a really small subset of the folks that they're seeing in custody.
Oh, it's very complex. Yep. Thank you.
Yes. All right, let's see. The report also listed the volume of patients, in this case about 64 a month. In terms of staffing, do you have a number of how many staff members are assigned to handle this type of caseload normally?
I can speak to that. So we have one social worker who specializes in substance use treatment. We have 2 rehabilitation counselors, and we have 7 medical doctors, and 2 of which are addiction specialists, myself included.
Okay, good, thank you. In terms of the transfer to ER, approximately how many ER transfer occurs related to the substance abuse? Would you care to guesstimate?
So I can give you the previous 3 months data.
Okay, good.
In July, it's 4 for alcohol-related issues and 1 for drug-related issues. In August, it's 1 for alcohol-related issues and 3 for drug-related issues. And September, there was 0 for alcohol-related issues and 3 for drug-related issues. And in context, we sent about, on average, about 150 patients out to the emergency room per month. So it's relatively low.
Right. So what I guess I'm trying to scheme from the report is that our jails really are not designed or equipped to provide a sustained recovery environment, and individuals in custody often remain exposed to substances and other negative influences that undermine these treatment efforts. And of course, one of the most surprising thing that I certainly did not learn until I got on this board of supervisor is that there's still drugs inside the jails. And it's very creative of how that's being delivered, whether it's smuggled through individuals and folks use technology like drones are being flown into the courtyards of Elmwood, for example. During my visits, I've learned that they drop them off and folks were able to pick that up during times outside, and of course that's how it gets in the system. And so I would say that we really have a critical gap in our own system here. And the lack of the secure therapeutic treatment facility, and that would allow for the true recovery support rather than the continued cycles of this incarceration and this type of relapse. So as we start the process of building our new jail that we've been talking about on the PSJC side, these are some of the data points I think we need to keep in mind to make sure that we also stay focused on the rehabilitations part and not just a matter of retribution punishments model, which they used to be, how the jail was being built previously. And the other thing is I do want to mention that there was at the direction earlier I would like to talk about is for having some type of audit like Harvey Rose to look at a process of developing an independent audit of the custody health services on some of these things to help identify these gaps in the future. And I understand the gaps have been under the court order, right, related to inmate care, but certainly this isn't exactly why I think some type of audit will be necessary to help find the gaps and so that we could be done independently and without the intervention. Yes, go ahead.
I just want to note just remind the committee, we have a litany of independent folks cycling through the jail who have specific expertise in these areas, court-appointed monitors under the consent decree. We have the Attorney General's office. We've got OCLAM. We've got like many, many sets of folks. And it is a significant operational challenge to the day-to-day operations with the repeated cycling through of people nonstop with all of their own opinions on exactly what we should be doing. I worry, candidly, that adding another audit on top of all of those is going to be a net negative, given how many sets of folks are cycling through focused on all of these issues. So obviously it's the board's prerogative if the board wants to add that to a subsequent work plan for Harvey Rose. But we do have medical monitors coming through, and we do have these issues as a specific part of the consent decree. I do also know that County Council is providing a comprehensive update on that status at the closed session on Monday.
Sure. Why don't we wait till we get that closed session report from the County Council on that issue, but I just want to highlight the need of some type of
there's definitely, and it's a
oversight.
huge area of the monitoring is associated with the medical care and the mental health care, both,
Right.
in custody and custody health. And it's an area where there's very concentrated focus. So I'm just naming, we've got a lot of cooks in the kitchen there.
Right. No, I think it's helpful, and I think sometimes when you have too many cooks in the kitchen, like I said, the necessary dish that's being cooked up is not necessarily good. More necessarily is better, right? I've always had the argument with my wife. Sometimes she likes to put everything into a dish, into the wok. I'm like, honey, this is not making it better. And I certainly don't want to make that same mistake here when it comes to something this big. No, I get your point, James, and but I certainly would like to hear more from the closed session report. And how basically we're just trying to find gaps.
Absolutely.
And this is what
No,
we're
I think
working
100% on that. It's just like how many layers?
on. How many layers? Yes, go ahead.
Is
Vice Chair.
there, it sounds like given that there are a lot of folks monitoring groups, is there a way of compiling all of that to figure out where the gaps are?
Right.
Or is that already being done?
It is,
This is
yeah.
very
So
new
we
to
have,
me, so
yeah. So
Apologies if I.
So I think we can really lay that out in more detail in the Monday discussion. But we have our website with the report card that shows, and you'll see if you look at that, just how significant and wide-ranging the scope is. So we're focused on one very specific element here. But for both custody and custody health, it is basically every facet of the operations, from use of force to mental health to ADA compliance to facilities-related concerns. It's the entire range of things. We do have public report cards that show publicly where we are on every single item. You know, there's hundreds of items under the remedial plans from the 2 consent decrees that are being tracked and monitored, and that are subject to a whole suite of court-appointed independent monitoring. We've made tremendous progress in some areas. So for example, you'll see on the dental work that's happened, we've really done some phenomenal progress, and things are moving in a really excellent direction. And there's other areas where we've encountered other challenges, and there's areas where, as we've said both publicly and otherwise for many years, we are significantly stymied by the current facilities. In other words, there are elements of those plans that we cannot resolve in the current facilities. But we have that, we do have it on the, we do have it publicly reported on the website. It's updated quarterly on the website, and we will be having a really comprehensive conversation, like I said, in closed session, given that it's also active litigation.
Okay, thank you, Chair.
No, thank you. I think this is something that we need to definitely continue to look at. And yes, go ahead, Greta. You think?
I just wanted to add one thing to what James just shared, which is, I am particularly looking forward to some of the recommendations we're anticipating from the entity with whom we've contracted to do our comprehensive facility assessment specific to substance use treatment, space, and capacity. That is definitely a particular area where the facility challenges in our current space are acute, and where we're anticipating some very specific recommendations on how facilities should be modified, replaced, or reutilized to enable our staff to do some of the things that they would love to do to improve treatment, but currently cannot do given some of the space challenges that we have in the current facilities. And so I think there may be also just a timing opportunity to really focus in on this when we come back with recommendations related to comprehensive facility planning that will enable some, what we hope will be really significant improvements in care by virtue of facility and space modifications.
Okay. All right, that's it. All right, thank you. Yes, go ahead. Let's go ahead and get a motion to receive report.
I will make a motion to receive the report. Thank you.
Okay, I'll go ahead and second that as well.
Vice Chairperson Abe-Koga.
Aye.
Chairperson Lee.
Aye as well. Thank you
Motion
very
carries.
much. Yes.
And to the chair, would you like to take item 5B before going on to number 8?
Yeah, actually, I'm going to wait on 5B when we talk to Mr. Lawrence, and maybe have him give me that update at that point when he gives the report. I think that'll be a good time to Rep all that at the same time. Yeah, thank you.
Thank you.
Okay, moving to item number 8, is a report from proposed changes to the 2026 legislative policies and health systems chapter.
Good morning. Happy Friday, Mr. President, Vice Chair Avekoga, David Campos, Deputy County Executive, and I'm going to turn it over to staff from our IGR department, County Council, and our hospital system to introduce themselves.
Good morning and happy Friday. Monica Tong, Intergovernmental Relations.
Amy Carta, County of Santa Clara Health System.
Good morning, Mary Hannah Weir, Lead Deputy County Counsel.
Good morning, Elaine Trin, IGR.
Good morning. Today we're here to talk about the county's legislative policies, and as you will hear from Monica and others, there are different pieces to what we call the county's legislative platform. And one of those pieces, which is really the focus of this presentation today, is the policies document, which is a long document that essentially outlines the county's, the Board of Supervisors' position on a number of policy issues so that when we, as the Intergovernmental Relations Office, see and deal with the thousands of bills that come in at the state and federal level, we don't have to come to the board every time a bill is introduced. This process of finalizing and reviewing this document is a very extensive process. You may recall that there was a study session that the board held early in the year, and it really engages all of the county departments, and many of the folks that specifically provided input on this section that deals with the health and hospital system are on the dais, and some might be online as well. So we're very grateful to all of the county departments that worked to review this document. You may also recall that this document got a very extensive, actually for the first time, review last year because it hadn't actually ever gone through that review and rewrite. But as we know, a lot has happened in the last few months at the federal level. So we have asked, notwithstanding that extensive review from a year ago, departments to go back and review their respective sections with an eye towards are there things that should be changed in light of what's happened at the federal level. If we can go to the next slide. And so that really is the purpose of this, and we are grateful to every department that has engaged in this process. We are grateful to County Council that played a very important role in this review, and of course, with respect to anything involving the health, the health and hospital system has been very active in this process. So with that, I'll turn it over to Monica.
Thanks, David. As David mentioned, the legislative platform consists of 4 different components: the policies document with the suggested edits for 2026 in the report today, bill ideas, priorities, and one-time funding requests and budget. Please note that the written report that is in your packets are a point in time, so we'll be sure to provide the updates with everything that happened since Monday. The legislative policies document does provide IGR with the authority to engage legislation. The state legislature ended its 2025 work on September 13th, and the governor had until October 13th on Monday to take action on bills presented to him. To highlight bills engaged in the HHC policy area, AB 82 by Assemblymember Ward was signed. AB 309 by Assemblymember Zabur was also signed. AB 546 by Assemblymember Caloza that the chair had some interest in was vetoed by the governor, citing unintended consequences of creating disparities and inequities for individuals with other health conditions, but also voiced concerns about costs and coverage that is beyond basic health. AB 554 by Assemblymember Gonzalez was vetoed as well, citing concerns that costs would be imposed onto consumers. SB 257 by Senator Wahab was also vetoed by the governor, citing cost concerns. And SB 378 was signed into law on October 6th. I will now turn it over to Elaine to talk about our process for the legislative policies document.
Thank you. As David mentioned, we are in the process of updating our legislative platform. We're currently providing each of the board policy committees with the appropriate chapters for review for suggested edits to the legislative policies document, and with the goal of returning to the full board November 4th for board approval. As Monica mentioned, the legislative policy provides IGR the guidance and authority to engage in legislation where we communicate our support or opposition on bills. And we may come to the board on a case-by-case basis to seek board approval on emerging policies that are not covered in the legislative policies document. So a quick overview of the proposed edits to the health system chapter is we, as David mentioned, updated the statements to reflect the changing dynamics of the Congress and state legislature. We also work with the departments to identify any issues that are on the horizon that may have been flagged by associations. We are continuing efforts to delete statements that have been resolved, consolidate statements where possible, and also to move statements structurally so they're organized topically. So some of the statements in the health system chapter may be found in CSFC, FGOC, PSJC, et cetera. And so the red line document is included with your packet. And now I will turn it back to David.
Great. Thank you very much. Again, we are grateful to everyone who got involved, who was involved in this process. And as was noted, our plan is to, as we're doing, to take each one of the relevant sections of the policies, which are organized by board committee, policy committee, to each committee, and then we're going to the full board in November. And why are we going to the full board in November, and why are we asking the board to act before the end of the calendar year? Because of how quickly things happen in Sacramento and in DC. The earlier and the sooner we have the authority and the guidance, the better and the more effective we will be in terms of protecting the interests of the county. So with that, we're happy to take questions. And again, we have department heads who worked on this section that are available to answer any specifics depending on your questions. So back to you, Mr. President. Thank you again for your time.
Yes, thank you very much, David, for the good report and team. Just checking, any public have any comments on this one?
We have no speakers on the item.
All right, let's close the public speaking portion. Vice Chair, do you have any questions?
Thank you, Chair. Thank you very much for the update and the report. Really appreciate the addition of language that you've included regarding the county opposing policies, programs, and regulations that would negatively impact access to the full range of affordable health care for all, emphasizing for all. So thank you for that. Couple of questions. When I know that there's thousands of bills and 357 in particular that have to do with our committee here, it seems like it's quite a large number of bills to have to track. So my question is how extensive is your level of does this allow in terms of, given your staffing too, in terms of your level of engagement, like how deeply are you really able to engage realistically in light of the number of bills and the fairly modest staffing that we have in IGR.
We know, and I know the county executive wants to add something here, so maybe I'll defer to him first.
You're right that there are thousands of bills, right? And as a county government, a disproportionate percentage of the bills affect us because so many state programs are administered through counties. This has been a challenge for a number of years. We rely on the engagement of folks across the county organization to flag bills of interest and focus. So obviously coordinated by the IGR team, including the county council legislative team, but farmed out to departments and to the advice attorneys across the county council's office to go through and then identify those bills that should be flagged and monitored. It's also fortunate in a way that many bills don't really advance beyond the initial stages of the process. And so we really do a deeper focus on those bills that are really moving forward in the process. And we also rely on statewide associations. Every county function that is a state function has a state association. So for example, there's the California Welfare Directors Association, there's the Association of the Public Health Officers, there's the, every environmental health, every single kind of county function that's really a state function that's administered at the county level has some statewide association of those directors from the 58 California counties, and they focus in on those specific areas as well. But it is a difficult task, and I will tell you, every year there are important bills that only pop up on our radar very late into the process that we wish we had had some more visibility into earlier. The other thing that makes it very challenging is that some of the most significant bills that affect us are either budget trailer bills or gut and amend bills that show up very late in the process and under the California Constitution may show up with as little as 72 hours notice. And some of the most consequential things that impact us, especially fiscally, are done behind closed doors and then show up at the last minute. So we try to have our ear to the ground and do our best on that. That's why we're always on the alert, for example, about anything related to excess ERAF that might show up as a trailer bill at the last minute, at the tail end of the budget process, as just one specific Santa Clara County priority example that we have had to attend to for years. But it is a challenge. It's a big challenge. I will say we do, I think, more than any other county in this space. We have an excellent team, but we've also augmented this team. If you compare where we were at, just a handful of years ago, even, to try to have a better handle, and in realization and recognition of the fact that state legislation has such a big impact on what we do.
The one thing that I would add to what the county executive said through the chair is that it really is very painstaking work that requires daily attention and detail. And that's where I think our staff really comes in. They go through every single bill. They try to identify those priority bills for departments to look at. But as we have said to departments, the board's directive to be as engaged as we can be in Sacramento is unattainable unless departments are involved. So departments really have to pay attention to those emails that say, can you look at these bills? And there are times when, you've seen it here, when issues come up about a bill and we point out, well, we never heard from you on this. So that's why we ask departments to pay close attention, because that detail is really key to our success.
Great, thank you. A couple of other questions. Do you have some thoughts on bill ideas at this time?
Yes, and in fact, we go through a very extensive process. In the summer, we go through this exercise with departments. There's actually a form that we ask departments, and actually county Board of Supervisor offices also to submit, that ask a whole range of questions about the particular issue. And, you know, we look at sort of ideas, you know, more than half a year before the legislative session because of how legislation works. We are in the process of finalizing our review. We are grateful to departments who gave us a lot of ideas. And then we are going to bring those ideas to the board in November.
Okay.
And of course, we have met with individual board members to share some of that detail, you know, to make sure that we also get from you your priorities.
Great, thank you. One request, looking at your chart, you had the funding piece, and we talked about this at our last meeting. From the AAPI health assessment, the outcome of that was a community worker outreach program. That funding ends at the end of this year. I know that the nonprofit organizations have been looking for funding elsewhere, but I know things are tight everywhere, but I recalled a few years back that at the state level, the AAPI Legislative Caucus was able to get a significant amount of funding for AAPI activities. I don't know where they are with that, but that's a ask that I would like to make to our legislators if there are opportunities to continue that program. I think it was in the $300,000 range, but would like to see what we can do to get assistance in continuing that.
We will take that into account. In fact, the timeline for
okay
what
with
we're
that,
calling budget requests is the end of the calendar year, and there's also a form that we ask people to fill
Okay,
out.
great.
But we will make sure to follow up on that, Supervisor, and then we will strategize with you to figure out who might be the best target in terms
Yes.
of the ask. And for folks that are watching this is sort of the state or federal level equivalent of an inventory item.
Yes,
And there may be an
earmarks,
opportunity to do one or the other, or perhaps even both.
Yes.
The federal request, of course, right now is kind of in limbo in terms of
Yes,
not
it
clear
is.
how the Senate, the state, the Republican Party will, in the House and in the Senate, will treat those requests. And of course, the challenge with the state is just the lack of funds, but we will definitely work with you on that.
Thank you. Yes, so from time to time, I get asked by our state legislators if there's any kind of funding requests we have. So I would just ask that you bring that up, and then when the opportunity arises, they could advocate for that. But just want to make sure we have that request in, since that is a very important program.
Absolutely.
Yes.
No, it's very helpful to hear that and incorporate that, because one of the things that ends up happening, and that's why we have actually done this process, which is newer for us. We used to get some of these requests from legislators very last minute. And then we would be scrambling to identify and have stuff. So having the list of things, even if we don't have a
Ready to
vehicle
go.
at the moment,
Yeah.
a vehicle may appear
Yes.
at the last minute. And so we like to have these in the queue
Yes.
ready to go.
Yes, great, thank you. And then one final thought, just in terms of your IGR reporting, and as the president of the board, I would ask for your input on this. But in my other committee in Hewlett, we had a similar report out and a little conversation about how to keep the board apprised of changes, and definitely understand and support the flexibility that all IGR team needs to move, because things move very quickly, but just for the board to be apprised of as often as possible. And I know I've talked with the county executive about this too, but could we look at having a standing IGR report on like maybe once a month on our board meeting agendas, the Board of Supervisors meeting agendas, and it could just be a written report. It's similar to what the county executive and county council has as a standing report out so that the entire board sees what's happening across all of the committees.
So I can give an update on that. So we are planning to do that.
Great.
To have them, right now, we do that monthly at FGOC.
Yes.
And the FGOC chair was also agreeable to just moving that to the full board so that we don't have to do it twice.
Exactly.
Great.
So she was supportive of that, and so we're going to start that process of having at one board meeting each month. We will have the IGR update that normally would happen at the committee happen just with the full board.
Perfect. Thank you very much. Thank you.
Great, thank you so much. David, on those vetoes that we talked about, I know the California, well, federal constitution as well, but the California constitution does provide a mechanism to override a veto, technically speaking. But I don't think it's ever happened.
Well,
that
it
I know
has,
of.
but not for 40, 50 years. It's been a
Yeah.
long time since the legislature has overridden a gubernatorial veto.
In other words, it's been a norm or practice, not a law, right?
Right.
That we do not, quote unquote, mess with the governor's veto. Once his veto is dead, basically.
That's correct, and quite frankly, I don't see that changing in the near future. And the thing about any effort to override a veto, and as someone who actually, as a supervisor, engaged in that process with Gavin Newsom being mayor, is making sure that, you know, if you go down that path, that you're successful, because if you're not successful, there will be consequences for that. So I don't see that happening, Mr. President.
Yes, we all have heard the potential wrath from some of these. I think it's actually sad in many ways, because the fact that some of these vetoed bills obviously has very good reasoning behind it, and most of it has been passed by unanimous, if not a super majority of the votes, and these type of vetoes kind of set back these efforts for at least one term, if not ever. So I feel very sad that some of these really good ideas are not going to be implemented. But okay, and that's all. Yeah, that's all the questions I have on this one.
Thank you. And again, you know, one thing that I would say in the, you know, healthcare space, which in so many respects, because of how big this item is and the magnitude and the critical importance of these services, you know, this is the top priority for us in terms of what we're trying to accomplish. And one of the challenges that we see is in this space, a reluctance on the part of the administration to inject more revenue, which we believe is needed to be able to deal with the level of cuts that we're facing. And we hope that the legislature will be able to push the governor on that because of what's happening. And, you know, I think that one of the things that I would say, especially around healthcare, is that you see a greater deal of coordination between IGR and the health system in a way that I think, you know, is unprecedented, and I think we have to, because of everything that's happening at the state and federal level. And Mr. Lorenz and his team are very involved in everything we're doing, and we're always strategizing in ways to maximize our influence.
Thank you. All right, no further comments. I got a motion to receive the report, correct?
Yes.
And we second it, and let's take a vote.
Vice Chairperson Abe Koga.
Aye.
Chairperson Lee.
Aye as well.
Motion carries.
All right, moving to item 10, our last item for the day, relating to our current and emerging healthcare issues. And presenting this report is our Chief Executive of our Santa Clara Valley Healthcare, Paul Lorenz. And in addition to that, Paul, may I ask you to also address 5B regarding our county efforts to address impacts of the federal and state funding landscape as well? Thank you.
Thank you, Chair Lee. So let me first start out by sharing that RMC continues to see growth. The average daily census grew another 7% month over month from August to September, reaching an ADC of 178 for the month.
That's great.
Surgical case volume has also grown by 22% over the same period. Gross charges for regional medical center grew by 6% month over month, reaching $170 million for the month of September, which obviously is showing favorable financial performance to budget because of those improvements that we're seeing.
So are we breaking even almost?
Are we breaking even? Well, from a budget perspective, we're actually performing better than budget. That does include the county contribution, but obviously that contributes to the overall financial performance of the entire system, which is really favorable in that respect. So we are moving in the right direction as a healthcare system. The problem we have is that the dollars that we're talking about in terms of dealing with HR1 are so significant that we will have to make some difficult decisions.
So the takeaway is, had there been no HR1, based on these numbers we're looking at, the purchase of RMC has been a huge win financially. Would you say that's correct?
It absolutely has been. As you well know, if you look at from the year prior to the acquisition to the current year, there has been no additional county contribution to the entire health system with the acquisition of Regional Medical Center. So
Yeah, I just want to emphasize what Paul just said, because I think people really have not understood this. We bought a hospital. We restored trauma. We restored STEMI stroke services. We've now restored labor and delivery services. We did not increase the general fund contribution to the system by 1 penny. In fact, on a percentage basis, whether you look at it as a percentage of general fund or you look at it as a percentage of the health system's budget, either way, on a percentage basis, that contribution has declined in both of the last 2 years. So, Regional has been a tremendously successful story financially. Of course, even more importantly, it's been a tremendously successful story from actually delivering healthcare, life-saving healthcare to folks. And the system as a whole, but for HR1, has really stabilized its finances from what happened right in the wake of the pandemic, which, by the way, if you look at every publication, everything about healthcare financing, public or private, anywhere in the country, but especially here in California, that in the wake of the pandemic, very significant cost increases. And those were, of course, reflected in our system as well. So that has not just stabilized, but declined in both of the last 2 years, and on track to further decline in the upcoming year, but for HR1. And that's just the numbers. It is a real testament to the diligent work in our system and just how smoothly that transition has been. So one of the other things I would just note on Regional specifically is because we were able to get HealthLink up in 80 days, which we got an award for that, by the way, from Epic. But because we were able to do it in 80 days, we didn't have carrying costs to HCA to continue to use their health system. Because of how we have been integrating service lines, because of how quickly the census was able to get up, we've been able to cover fixed cost. And so you look at all those metrics, we're way ahead of what we thought was even possible. And that is because of the really excellent work of the staff at Regional and across the health system and the other support departments, like TSS, for example, in the case of the electronic medical record. So it's really an extraordinary success story.
And that's why I just want to go back on this very point, and that is, oftentimes we hear people say, why don't government runs better like businesses? Right? Just think about that. Because today, we have a real life example of when business runs this hospital to the ground. They have to close labor and delivery 5 years ago. They have to close our trauma center a year and a half ago because they couldn't make money out of it. And when we took it over as a government entity, not only were we able to restore these services, both of them we just talked about, we actually make it financially black. And I think that is the takeaway story that people really need to talk about, because some things government is definitely doing better than business. I just want, you can argue all you want, but this is fact, right?
And I'll give you the very concrete example. The Epic, this is the international company. It's the top of the line electronic medical record used at the top flight public and private systems across the country. Their timeline for implementing at a hospital is 12 months. And we did it in 80 days with our staff in 80 days. That's why they give us this award, because they were blown away by that timeline.
Yes.
And they do this implementation all over the country in systems. And so I think that very plainly makes the point that you just raised, which is, what we've been able to do here and the resources we've been able to draw in. Which is why when people look at something like per capita spending, for example, that's the wrong question. That represents, of course, service delivery. The question is, what's happening with the revenue? And the revenue has come in too. And so, looking at things from only one side of the ledger and not the other is just mathematically deficient.
Right, so I think it's highlights that point. So I belabor this point so much, Paul, because it's such a good news story that I think it needs to be told. And then also, no small thanks to your team and those who have put this implementation that happens right here. And the fact that, we did have a acquisition of 2 separate hospitals prior, and there's certainly a lot of lessons learned, right, James? Through that purchase, we knew what not to do. And through that lesson learned, I think helped the Epic, implementations much faster and everything else as well.
Absolutely. Yeah? And we were able to change rules, right? The merit system rule change that we were able to make allowed the onboarding of staff to go so much better.
Faster.
And that is an example of where we took a lesson learned, we got partnership from our unions, right? We had a joint committee with SEIU. We got all the other unions to sign off on it. We got a rule change in place, and it facilitated this in a very smooth way, which also shows what happens when we have those partnerships and we're able to look at things structurally and facilitate the work that needs to happen. So, so I'm very just proud of the work of our staff with regional. It's an incredible success story. I think it's going to continue to be a resounding success as well. And the challenge in front of us is, what do we do with HR 1 and what the federal government has done? And it turns things upside down, and we're going to have to manage through that. But I will say, if we can get the space in the runway, and we need that because this is a big system. But if we can get the space in the runway, we can adapt. We will adapt to the financing structures and figure out the next best way to maximize the revenue resources to sustain the most critical services. But we need that runway.
Right, and many people have followed me and understood. I've always been telling people that I have no shame about taking good ideas from other jurisdictions, other counties, other cities. And this is one time I think we should share the best practices of what happened with the whole RMC acquisition and the results, and start using this as a case study practically, and send to business schools, send it to different jurisdictions so they could learn from what we do. That way we could help save many potential hospitals that might be closed by these for-profit hospitals, so that their counties and their government agencies could be able to absorb and make it successful.
You bet, and there's been aspects of the county's work that have already been highlighted at Stanford Business School and elsewhere from some system changes in the past. There was a recent Harvard study that just came out that talking about the health outcomes with private equity. And it's really salient because what's happening across the country is private equity is taking over what used to be nonprofit charity care hospital systems and extracting capital out of those systems, and then they're going under. Well, we know that because we literally saw that happen here. That's what happened with the Verity takeover of the Daughters of Charity hospitals that led them to bankruptcy, and then we ended up being the only bidder to save those hospitals. And in those handful of years that Verity was operating those hospitals, that's exactly what we saw, which is worse outcomes and the extraction of all the capital out. And this Harvard study talks about how this is happening nationally, and the very clear healthcare outcome differences as a result of that. Of course, there's also the impacts on local economies, on people's, on the employees, that on top of the health outcomes as a result of what's happening. So we have a lot of important, really powerful stories to tell here on this work. And some of it's been shared already. The EPIC piece was highlighted by EPIC itself. And we'll continue to find those avenues.
Great, thank you, James, for sharing that. Yeah. So after all that bad news we received from Ms. Margolin federally, not our fault, right? But certainly this is something that we did, that we all did here, and really, really glad to hear these great news. Thank you, Paul.
It is great progress. And I would add, obviously, we talked about labor and delivery in NICU. October 20th, we're hoping to have our first baby at Regional. But as much as we talk about Regional Medical Center, I do have to really take a moment and give a shout out to O'Connor Hospital, the leadership there, the staff. As you well know, we're transitioning it from O'Connor Hospital to Regional. There is absolutely no way we would have met this date and brought these services back to the community with their commitment. And O'Connor Hospital, in terms of the labor delivery service, they've had a legacy, in terms of decades of service to the community. In fact, many people that you talk to in the community will say, I was either born at O'Connor Hospital, born at Regional Medical Center, or at Valley Medical Center. So all three hospitals have an incredible legacy, and I do want to acknowledge the staff. They embraced this transition. Change is never easy, but it will help us because it provides service in the community where we see the majority of those deliveries. It allows us to actually provide more access and actually have a better result in terms of our financial performance because of this. So it's going to continue to roll forward, and I just want to acknowledge the staff there. With that being said, I know Supervisor Abekogi wearing pink, James is wearing pink. This month is Breast Cancer Awareness Month. It is the most common cancer among women. The lifetime of risk of developing breast cancer for women is around 1 in 8. And your healthcare system continues to focus on these services for our community. We offer a program that's called Every Women's Count, which provides for free breast cancer and cervical cancer screening and diagnostic services. I want to point out that our outreach through that program has resulted in patients receiving care. 86.8% of the patients that we've outreached through this program identify as Hispanic or Latino. Obviously demonstrating some really strong outreach to our community that is disproportionately affected by this. In the past year, 556 patients received services through this program, this free program. 21% were diagnosed and then ultimately connected to treatment and services within our system.
That's great.
So if you think about 556 women, 21% of them receiving care, needed care, that's really an important topic and success to show to our community of what this healthcare system does. Because as James had indicated at a meeting yesterday, we can give us all the numbers and show where we're performing and how we're performing. But it really comes down to the individual patients that we care for and the community that we care for. So I really wanted to touch on that since it is October and Breast Cancer Awareness Month. With that being said, I'm happy to take any further questions. Although I think, Supervisor, you did ask me about some of our effort regarding our intergovernmental relations, our work with DHCS in the state. We are working very closely with IGR, but also with our State Public Hospital Association in trying to address some of these HR 1 related impacts related to our supplemental payments, programs such as the Global Payment Program, the DISH program where we're expected to lose funding this year. we are working with them to really reframe how we can actually continue to utilize the 1115 waiver and other programs that can kind of move around some of these direct related HR 1 issues. We are spending a lot of time trying to figure out how to work with our delegation to make sure they understand, but also work directly with state officials to support us in our effort from an administrative standpoint to maximize our revenues for Medi-Cal. And there are those opportunities, but we have to be front and center in those discussions with the state and not just with our delegation. So we are, of course, paying very close attention, and we will report back as we make progress.
Yeah, thank you, Paul. I just want to mention that we use a lot of acronyms on the dais. I see some of the audience watching here today, and I just want to mention HR1 is the House Resolution 1, and that's the one that the President has called the big and beautiful bill. And that's a not so beautiful bill that's hurting our county about $1 billion a year on revenue losses. $1 billion a year. I just want to remind people of that fact. And that's the reason why we're working so hard right now, try to find ways to fill that gap and try to save our hospitals. And this is what this discussion is about, yeah. So I just want to make that clarity. Go ahead, yes, Vice Chair.
Thank you, Chair, and thank you so much for a lot of good news in this time of not so great news. And just want to thank you, Paul, and your entire team for all of the incredible work that you are doing. Certainly, as the Chair mentioned, there are some things that government can do well, and when you don't have to worry about making a profit or having to pay out to your shareholders, being able to really focus on quality care, and then whatever revenue that is generated to be able to put that back into the system is what really is important and helps to maintain our quality healthcare system here. And I was just speaking to a group this morning about HR1's effects to the county and how really the healthcare system is so interconnected. And just thinking about, well, what would it be like if we didn't have 3 hospitals, right? The 3 that the county acquired. I think our state of our healthcare system would be at a much lower quality, and trying to emphasize that to the community, I think is really important for us, and to be able to highlight these positive stories is really important. I also just do want to thank you. I learned about this Every Woman Counts program, and it really is amazing that you've screened 556 low-income women and saved, and to be able to come up with 21% who were actually diagnosed with cancer. That's 1 in 5. Really quite incredible. You've saved these women's lives. As a breast cancer survivor myself, coming up on my 10th year since diagnosis, I really know personally the importance of these screenings. Early detection is the key to being cured. And so I just want to thank you again and your team for providing this. We're actually going to be putting on a Women's Healthcare Summit with Latinas Contra Cancer on October 28th in Palo Alto, and we'll be sure to highlight this program. And please let me know if there's anything else I can do to support this effort. Thank you very much.
Thank you, Supervisor.
I just wanted to add one thing to your earlier comment, Supervisor Abakoga, which is there was a really powerful hearing at Special FGOC yesterday focused on the whole litany of impacts from federal cuts, and I wanted to draw your and the public's attention to a specific component of that, which is from the EMS agency, modeling the impact to the 911 EMS system from a potential closure of just one of the hospitals. And the numbers are truly staggering, and the volumes are just so significant, and impacts are so system-wide. So I would encourage everyone to take a look at that. I think the whole session's obviously online, merits everyone's attention, but that component in particular is just helps represent what we're talking about when we're talking about facilities being open or not, and what that means for the entire community and all the hospitals across the county.
Thank you so much. And I can't agree further about the issues specifically on the breast cancer. It's early detections, everything. And I do want to acknowledge the great work about the dense breast tissue issue that's been raised by our former colleague, your predecessor, Supervisor Smidian, who's been a champion on that issue and has certainly brought that to light and make that a very big issue, such that I do think that our county is now providing probably some of the best services on that specific area because of that the work that he did. So I just want to say thanks. All right, anything else, Paul?
No, Chair.
Okay, thank you very much. All right, let's moving on. I believe normally our public health officer, Dr. Raman, will be here, but today we have a substitute. Go ahead, please.
Thank you. I'm Dr. Monica Roy. I'm the acting deputy health officer here to represent the public health department. So just two very brief updates. One, earlier this week, all 13 Bay Area health officers joined together to release a statement encouraging all Bay Area residents to get vaccinated for COVID, flu, and RSV this winter respiratory virus season. And the second update, in follow-up to some discussions that had been occurring here, we've launched a social media campaign to address vaccine misinformation. So I wanted to share that, and I'm open to any questions.
Yeah, you need to be closer to the mic. You don't pick up
thank you.
your. I commit that all the time, so just to let you know. No,
Thank
so
you.
Don't do that. So my question about the different shots we have is, so we're talking about 3 shots now, right? We have flu shot, we got the COVID shot, and RSV. Are those all available to everybody, or is there age issues?
These vaccines are available to everyone for the flu and COVID vaccine 6 months and older. The RSV vaccine, there are 3 main populations that benefit. This is pregnant women, young infants, and the elderly.
Okay, so if you're not those 3 categories, can you still get those vaccinated? I mean, can you still request to get that vaccine?
So, so the RSV vaccine is specifically recommended for those 3 populations. The flu and COVID vaccines are recommended for everyone aged 6 months and older. There are certain individuals for whom it's especially important. Those include elderly individuals, people with other health conditions, but importantly here, because of the work that's been done with the Western Health Alliance, that's the 4 states of California, Oregon, Washington, and Hawaii, creating a pathway to ensure that there is access for anyone who wishes to receive the COVID and flu vaccine.
Right. Great. Okay, thank you very much. Anything else? Questions, comments? All right, good. All right, moving down the road, we have Dr. Terrell.
Yes, hi, President Lee and Supervisor Abe Koga, Sherry Terrell, Director of our Behavioral Health Services Department. You have our written report, but I wanted to just provide 2 quick verbal updates. The first is regarding the Psychiatric Emergency Response Team, or PERT program. On September 30th, we had the full discussion with the Board of Supervisors where the recommendation was to send letters to all 15 cities to create maximum flexibility if those cities were interested in continuing to provide or fund PERT services. So those letters did go out on October 10th. We are providing a deadline to those cities of October 31st to provide their decision back to us in writing. And so we will continue to follow up with those jurisdictions that elect to continue the PERT program.
Great, thank you so much.
Sure. And then just secondly, related to the Alcove program, we will be bringing back a report to the December HHC committee. And between now and that time, we will be engaging with some community engagement to hear from the community regarding their perspectives on the Alcove program.
Great.
That concludes my report.
All right, thank you. Any questions, Vice Chair?
Yes, thank you. And thank you for the report. Yes, I've heard that one of our cities has responded affirmatively in wanting to keep the PERT program, and I believe our actual county staff. So I think that highlights the importance of trying to maintain the program in some form. The other area is alcove, and I appreciate the report back. I know because of the budget, we are looking at some significant changes. But one I want to just highlight and share my concern with our North County and Palo Alto in particular, the residents there who are experiencing the wake of the recent suicide cluster that's been happening. And it's just, really heartbreaking for me to hear when young people are in such a state of crisis. And so I think it's so important for us to, continue to maintain our special services around youth mental health to protect our young people. And so with that, I understand we will probably have to look at changes, but one, I appreciate that we are going to be listening to the community, especially in light of what is happening in Palo Alto. There is a lot of concern, input, insights, and I just really want to make sure that everyone is heard in this process. And number two, that even though we may have to make changes, that we maintain the same level, if not higher quality of youth mental behavioral health services in North County. So I know we'll talk about this more in December, whether it's alcove or a different model. I know we'll get into more details, but I do want to be able to ensure to our residents that we will be maintaining quality services for our youth.
Great.
Thank you.
Thank you.
Thank you. And moving along with our Valley Health Plan.
Good morning, Supervisors. In addition to the written report, we have one quick verbal update we'd like to share.
Yes, please.
We're pleased to inform you that we just recently launched a pilot program to offer color guard screening toolkit at home for COVID California who's are over the age of 45 and have gaps in care, so they're missing preventive services. The color guard test is the non-invasive test to screen for colon cancer, and this is a covered benefit under VHP insurance plan. Even when we detect any positive result or test, we have a dedicated case management team to help the members to navigate through the care system. So with this new approach and pilot program, we hope to help the member to proactively manage their care, and also at the same time improve our quality measures, which contribute directly to our ability to maintain NCQA accreditation. Happy to take any questions on the program or any information on the written report.
Sure. I just wanted to confirm, you mean it's a colon care?
It's a color guard screening toolkit.
Color guard.
Yes, so it's
Colon guard.
color guard screening toolkit is
Okay.
screening for colon cancer.
For colon cancer.
And this is a brand new pilot program that we just partner with our vendor, Exact Sciences, to promote screening across of our memberships. In our pilot, we started with about 4,000 COVID California, and hopefully after the program, we can assess the effectiveness of the program, and then we can determine the next appropriate step to expand the program to the rest of the population.
Great. This is
possible.
very, very, very important. I mean, obviously, the colonoscopy will be the more comprehensive way to detect, and we have that done periodically based on the age and risk factors. But this is another way, which is a less invasive way. You could actually do this on your own. You bring it home like a kit, right,
Exactly.
to check out to see that there might be some colon issues ahead of time. Before colonoscopy. Yeah, okay, great. Thank you very much. This is very, very helpful. Yeah. All right. Okay, let's see. I believe that's the last report I am getting. And I think this ends up to the end of our items. Any other? Oh, sorry.
We have public comment.
Sure. Oh, I'm sorry. Okay, let's see. Any public comments on this item?
We have no speakers.
Okay, no speakers. Thank you very much. Always good to have the lawyer to remind us to make sure we followed all the, cross the T and dot the I, to not make sure we don't shortchange anybody. Okay, with that, thank you very much. This brings it to the end of our items, and we're going to adjourn the committee until December and see you all then. Thank you very much.